Very much, Eddie. We're just loading my question up so I went for a nod from Tim. I think before I start, it would be fair to say I think the most challenging area of cardiology for all of us is the electrophysiology study, and it's the one area in cardiology that I think has become very much a subspecialty of its own right. And therefore you will find on the majority of occasions that when we get things, particularly in the electrophysiology field, we will be very quick to ask for civilian advice to guide us, because things like Brugada and non-QT syndrome are rare, but clearly the impact of those are quite devastating. Okay, so this is my question. So in the Royal Air Force, pilots with established atrial fibrillation are allowed to fly in an unrestricted capacity if 1. Adequately rate controlled, 2. On digoxin, 3. If asymptomatic, 4. After successful ablation, or 5. Not at all. So please vote.
Got about 60 hardcore voters out there, haven't we?
Okay, good. I've got a bit of work to do, clearly. Fine, thanks, Tom. So what am I going to talk about? I'm going to talk a little bit about going back to basics, talking a little bit about G and the cardiac rhythm disturbances that generates. I'm going to talk a little bit about clinical assessment of arrhythmias, and then specifically, although I think with maybe a little bit more epidemiological background, specific conditions that we pick up regularly on routine screening on ECGs, including heart block, bundle branch block, some of the tachycardias which you just heard about, and I won't dwell on that, and then a little bit about ectopy and then VT. And I will just make a comment at the end about athletic heart and the fact that it's not a benign condition. What I'm not going to talk about is Brugada and non-QT syndrome, partly because that will cover the inherited talk that Riggs is giving later on, but I suspect there may be a number of questions about that at the end of the day. Okay, as I said the other day, sudden incapacitation is an obvious threat to flight safety. Again, we can mitigate that in dual pilot operations, and again, this is a major part of the risk assessment that we do. You can have a fair amount of risk taken on board, in my view, if you're in a dual pilot situation, with the exception probably of rotary operations. And again, one of the things we haven't really discussed today is dual pilot rotary versus dual pilot in a shiny aircraft that flies at 38,000 feet. And in my view, they are not the same thing. As I said the other day, careful screening and management of cardiovascular disease is essential to flight safety, and that is why we routinely screen these individuals. Positive G is known to cause cardiac arrhythmias. Again, a number of you will be aware of the studies, and these are mainly benign. Some of the US studies from USAF and the US Navy would suggest that a significant proportion of patients will have some kind of rhythm disturbance when you spin them as such. The vast majority of these are ventricular premature contractions, but actually a small number, about 1% of patients, will end up with AV dissociation, so for all intents and purposes, half. Again, the US Navy centrifuge study again shows some 93% of patients will have some kind of dysrhythmia. Again, similar demographic, male equals female, and nearly always asymptomatic. And the reality is that these cardiac arrhythmias represent a normal physiological response to the high G environment. However, they may be symptomatic, and they are often discovered on routine ECGs outside a high G environment. They may be associated with valvular and ischemic heart disease, which I'll come on to in a minute. And the real risks we have to consider are not just the distraction from the arrhythmia itself in terms of palpitations, but also the reduced risk of perfusion and the risk of thromboembolism, which was covered a minute ago in terms of atrial fibrillation. The standard gamut of tests, not surprisingly, much like my Swiss colleague said, would be echocardiography, a 24-hour Holter monitor, and exercise tolerance test. But actually, a number of these patients, depending on their age, may need further cardiovascular imaging. And as I've said several times, recent developments in electrophysiology and ablation may well change future recommendations. But again, one of the problems we have is the desire to get people up flying means that actually we need to be careful not to put people too early back up into the air and then find ourselves rescinding policy, because actually leg data would mean that we then have to change the policy back to being more restrictive. And as I'll allude to, we've found ourselves in that situation. As a general rule of thumb, all personnel become unfit service outside base area whilst investigated, and many will be grounded. Not all, however. A number of patients can continue flying in a restricted environment whilst under investigation. We also would include air traffic controllers, and again they are to be non-solo controlling whilst investigating. As I say, the as or with or grounded depending on their actual condition. So what is routine ECG screening for, and why do we do it as a routine? It's good for ventricular ectomy, it's good for showing you pre-excitation conditions, and it's good for showing you heart. I would challenge the assertion it's good for looking at prolonged QT intervals, because often there are things like U waves, and actually the vast majority of patients with prolonged QT in terms of the readout on the ECG turn out actually have a normal QT interval. And the other thing I would say there is the majority of people who have a prolonged QT in a one-off ECG is because they've been started on some form of medication that prolongs their QT. If you stop the medication, their QT was raised. Equally, left ventricular hypertrophy, we deal with a predominantly thin, tall population. So left ventricular hypertrophy in terms of the ECG criteria may well not be a good marker of true left ventricular hypertrophy. And it's good for obvious ischemic heart disease in terms of bundle, but it's not so good for occult ischemic heart disease, and therefore we have to use other investigations. One of the problems we always face is the lack of evidence from big studies, and one of the things that USAF have done over the years, as we heard about from General Jets, was the fact that they have these clinical working groups, and a significant proportion of those are looking at long-term outcome data on a number of cardiovascular issues and arrhythmia issues that we're talking about today. One of the biggest problems we have in screening young fit people is trying to determine what are acceptable ECG abnormalities that we will allow to fly without any restriction. And in the UK, we would accept a first degree heart block of less than 250 milliseconds. That's a completely arbitrary cut-off. We would accept partial right bundle branch block, that affects approximately 5% of the young fit population that we screen. A single ectopic beat, as you heard previously, but again, a Q wave in lead 3, and T wave inversion in one of the inferior leads we would let go. Bradycardia of greater than 40 beats per minute and no causes greater than 7.5 seconds. But there are other things such as short PR interval, and again, where are the cut-offs for these? There is really no evidence to support some of the statements that we make. So we take a pragmatic view a lot of the time. And again, what we have found over the period of time that we've been running our aviation medicine service is the fact that actually if we've got a yield of nothing after 2 years, maybe actually we're being slightly too restricted. So going on to the conditions themselves. First thing I'd say is before we go on, clearly if you're found to have an abnormality, these are the standard tests that we can do. As I've already mentioned, ECG criteria do not always mean that you have underlying left ventricular hypertrophy. And again, the debate about athletic heart versus true cardiomyopathy can be a debate that is difficult to untap. 24-hour Holtz monitors will often detect benign arrhythmias in young, but actually with increasing ventricular ectopy and things, actually it is surprising often how many different arrhythmias you may find. And again, we may go on, as you heard this morning, to use various functional or anatomical tests for investigating questions. So if we start off with heart block, I'm not going to quiz you on ECGs, but a complete heart block here. Essentially, as I've already said, first degree heart block, I'm not going to go into any detail because on the whole, the vast majority of them are less than 250 milliseconds and require no further investigation. This again, Mobius type 1 or Wenckebach is a common finding in young fit people with high vagal tone. It's usually asymptomatic and it's predominantly nocturnal on a 24-hour take. And if you've got otherwise normal, structurally normal heart and no other pathology, then essentially you would end up with an unrestricted flying case. Clearly, if you've got a widened QRS or you've got a significant burden of this during the day, we may require further investigations, but actually those cases are few and far between. As with ACLS, type 2 Mobius second degree heart block here has a high risk of degenerating to complete heart block, which is the next slide. Both of these generally are a disbar to flying due to the fact that you get significant cardiovascular problems. So moving on to bundle branch block. Right bundle branch block, as most of you are aware, can be a normal finding. And again, incomplete right bundle, as I said, is a normal variant that we see in fit young people. Complete heart block is often normal, but it should be investigated in Aircrew. And if you've got an associated fascicular block, you should treat it as left bundle branch block. And as all of those who went to medical school know, we were always taught that left bundle branch block is always associated with pathology. Clearly that is not true. In the UK, we have taken, or the Aircrew have taken the decision that even right bundle branch block pilot should be grounded whilst investigating. This is one of those rare occasions when the Aircrew is more restricted than we. In terms of some of the data that Eddie has alluded to that he's providing kindly, is the prevalence is relatively low, less than 1%, and the majority of people who are found to have bundle branch block have no significant coronary heart disease with a prevalence of around just under 3% here with a kind of 2.5% hypertension. You've already heard figures today, but actually the prevalence of hypertension generally is much higher than this. And again, if you follow these guys up for a significant period of time, again, the numbers of actual events and coronary disease are relatively low, and the deaths and the heart block associated, the death here is not related to the bundle branch. So since '93, essentially right bundle branch block requires only local evaluation, and since 2005 with echo only, and if normal there is an indefinite unrestricted rate. This is out of date, correct. And the policy is essentially the same whether you have persistent or new onset or abrupt or incomplete bundle branch. So again, the Royal Air Force, again, we would give you an unrestricted marker if all your tests are positive. Left bundle branch block is a slightly different story. It usually indicates some kind of underlying pathology, not always. All cases, however, do require specialist intervention and investigation, and in a significant number of patients, these will require further angiography, whether CT or invasive, to exclude coronary artery disease. And one of the reasons for that is that bundle branch block increases with age, and not surprisingly, increases with age alongside both coronary artery disease and hypertension. And it is pretty rare in people under the age of 35. I would say even up to 40, and be slightly different from the US in terms of their cut-off really for further investigation, slightly lower than ours. As I said earlier, as we've all said, I think with the increasing size and weight of our populations, these figures may come closer to. Again, slightly different story here. If you follow up patients with left bundle branch block over a period of time, 11% will have severe, in this study 11% have severe coronary artery disease, 6% with mild and 2% with dilated cardiomyopathy. So some 15% of patients have some kind of disqualifying endpoint at the time they're being investigated. And if you follow them up over the next 10 or 15 years, a significant proportion will then go on to also develop further coronary disease, and again a further 13%, so overall nearly 30% of aviators in this particular study will develop a condition that will disbar. Both the consult service and our RAF evaluation for persistent and rate-related bundle branch block is essentially the same. Left bundle branch block on exercises is often thought to be an indicative marker of underlying coronary disease, and clearly you go into the arrhythmia whilst you are increasing your myocardial blocks. Again, as I said earlier, the Americans would tend to investigate at the age of 35. We use the cut-off of 40, but we may well use both functional and anatomical testing. The key here is that nukes are not particularly good at bundle branch block. You can get a lot of artifacts, so this is one area where I would not use perfusion scanning with nuclear scans in this particular area. So in the US, essentially, if there's no underlying disease found, you can have an unrestricted waiver, but you will require evaluation on a fairly regular basis. We again take a slightly different view in the UK, where we will restrict you to essentially a multi-crew environment and in our lower performance aircraft. It is rarely compatible with that restricted catch-all. That's the catch-all phrase for allowing me to say that people very rarely can go back, but very can. So that's the bundle branch blocks and the heart blocks. Tachycardias are more common in terms of causing problems. We don't have a major problem with atrial fibrillation in the UK. We've just looked back at over 5 years of studies. In fact, we only have 35 patients with atrial fibrillation. Flutter is, as you've just heard, is deemed to be less compatible with retaining your flying status due to its unpredictability. And I again will just quickly talk about the catch-all SVT, both nodal and non-nodal reentral tachycardias. And then finally a little bit of VT. So AF is not an infrequent finding. Can be associated with excess alcohol, thyroid dysfunction, etc. And the key thing here is that it does have a significant effect in terms of impaired cardiac performance. You lose your atrial kick, so therefore you can lose up to 30% of your cardiac output. And also you have a desynchronous contraction of both the atrium and ventricle. And you can also get a very rapid ventricular response to exercise, and put people in a high stress environment, and clearly it's highly unpredictable. The operational considerations are not influencing. Paroxysmal atrial fibrillation, ironically, made more of a greater occupational concern than chronic AF in terms of the fact that there's more variability often. And again, the distraction may in fact be greater as people generate a certain tolerance to being in great control chronic AF. Again, just a bit of demographic data, again from the studies that I mentioned earlier. The majority of people will have an isolated episode, and that may well be related. We have a common phrase of holiday heart, where people go and they just drink a little bit too much, and that may well cause them problems. But there is also the phrase that AF begets AF. So one episode of AF means that you are significantly more likely to get further AF. And actually one of the things here in terms of the 19-year-old follow-up is actually in this population actually there is less translation from an isolated to a paroxysmal to a permanent atrial fibrillation than one might expect in a normal population. And that probably is a result of the mean age of this population being significantly lower than we see in normal civilian cardiological practice. And actually probably things like the left atria are therefore less dilated, and these people might be treated slightly more aggressively and earlier, and therefore you don't go on to develop a chronic established atrial fibrillation. Several recent civilian studies have essentially shown benefit of rate control over rhythm control, because many of the anti-arrhythmics we use are in themselves arrhythmic, and as you've already seen, the vast majority of the drugs that we use are not compatible with flying. However, rate control does do to patients who are lifetime risk of medications and potentially an increased risk of stroke, and that is clearly something that we are not going to tolerate in an aviation environment. A number of years ago, you'd find someone stand on the stage and say that atrial ablation would offer a cure. I think we have become a little bit more sanguine about that, and I think it offers a potential cure. But it may take 2 or 3 attempts. And these are procedures that, if you're not careful, may result in the patient having a pacemaker, bleeding the nose, or perforation. And it's not a benign procedure. And again, as we've talked about already today, I think you have to be very clear with your patients that actually, having an ablation, one, may not get them back to the flying status they want, and two, have potentially got some fairly serious, potentially life-threatening complications. It's successful in approximately 60 to 80% of the time. It is procedure dependent, and I suspect very much operator dependent, and most recurrences do occur in the first few months. However, and this is where we ran into problems, we took the view that, on the data we had at the time, that we would allow people to fly unrestricted after a period of time. However, recent evidence would suggest that actually there is a late recurrence rate, and therefore we have had to re-review our policy, which, believe me, is probably one of the more uncomfortable things, because a significant number of patients are older, therefore often more senior ranked, and having told them they're going back to flying to then take their flying restriction again can be quite an uncomfortable experience. In the civilian world, these procedures are nearly always performed for quality of life issues. Again, we would use them often for occupational reasons, but again, we have to be clear with our patients as to the outcome of the reasons. We will consider return to flying 6 months post-ablation if you fulfill the criteria which have already been gone through quite eloquently by my previous speaker. You must be on acceptable medication, and we would not only allow you to continue to go back to fly, but we would also follow you up for a minimum of 2 years. In essence, in the Royal Air Force, unless you have had a single isolated episode associated with an obvious precipitant, and you've remained essentially free of symptoms with meet the criteria I've just described, you will have some kind of restriction placed upon you. So the vast majority of pilots that we have who go into atrial fibrillation will not fly single seat again. And again, this is a rapidly moving field and policy changes. But again, we also need to consider the fact that a lot of these guys cannot operate outside a base area because they need relatively quick access to medical care. Flutter, as was described earlier, is a more uncommon finding, but usually and is often associated with atrial fibrillation. But your heart is often structurally abnormal. The real worry is the one-to-one conduction of that atrial beat at 300 beats per minute being conducted into the ventricle. I have to say I've seen one case of this in my entire career, and for many cardiologists they will not see this. So it is not as rare, but therefore it is a very rare phenomenon, but it clearly would have significant impact. As a general rule of thumb, if you subtract your age from 200, that's about the maximum rate you can tolerate. So if you're a 20-year-old guy, you can probably tolerate a heart rate of about 180 beats a minute without any hemodynamic problems. But the older you get, the less you can tolerate. And clearly, 300 beats a minute is going to be a struggle for anybody. Again, it often requires medication for rate control, and again, the usual line of therapy for these guys is to go on and have ablation. Ablation with atrial flutter has a very high success rate and often only requires a single trip to the lab, and the complication rate is in the region of about 1 to 200. However, there is thought to be a slightly higher risk of one-to-one conduction with recurrence following an ablation, and there is a later risk of approximately a fifth to a third for atrial fibrillation. But it's the higher one-to-one conduction that really forces us down the route of saying, actually, in the Royal Air Force, if you have ablation, you may well get back to flying, but we are unlikely to put you, or we will not put you in a single-seat environment. So SVT, again, I'm not going to go into the details particularly about the AV-NRT versus AV-RT, except to say that one incorporates the AV node and the other bypasses it. But again, both may well be distracting. Once you've had one episode, you are a significant likelihood of having another one, but it is incredibly difficult to predict as and when that might be. Both reduce your cardiac output and clearly may well reduce your exercise energy tolerance. AV nodal reentrant tachycardias are more common than things like Wolff-Parkinson-White, and account for about 60% of all cases. Your recurrent rate is approximately 100%. So if you have one episode, you are highly likely to have another one, almost guaranteed. And again, if you look at the data that the Americans again have found, with relatively large numbers of people, actually, if you've had a single episode, you've got a 1% risk of having an event per year, and if you have two events, your risk goes up even further. So, without ablation, essentially, you're disqualified for flying duties, whether in the UK or the US. Ablation is highly successful here. Recurrence rate is relatively low and again relatively early. But as I've already said, complete heart block is a risk, and clearly if you require a pacemaker, that's probably going to prevent you from flying full stop. In the States, you would end up being reviewed at the consult service 4 months post-ablation, and you may well be able to get an unrestricted waiver for flying training, particularly flying duties. Again, we take a slightly more conservative view, and again, we would say that essentially you can fly in an as or with environment following the ablation. And you must also have a very low risk of incapacitation. Again, clearly, as I've already said, approximately 30 people go on and potentially have AF culture. AV-RT, or the one we worry about really, is Wolff-Parkinson-White disease, and you can see the classic delta waves in the CCG. One of the things to be aware of is that there is a difference between having a Wolff-Parkinson-White ECG and Wolff-Parkinson-White syndrome. And again, we see a few Wolff-Parkinson-White pattern ECGs who are completely asymptomatic. It's really the symptoms that are really the main issue with Wolff-Parkinson-White. There is a hereditary predominance. It is more common in men than women, and in approximately 10% of cases, people are found to have more than one pathway. But there are associated risks of both sudden cardiac death and SVT. The sudden death rate is low, there's no doubt about that, but a significant proportion of people do develop symptoms. But essentially, the worst case scenarios for these people is the fact that the younger you find this, and particularly in children, that you have a worse outcome. WPW requires quite significant investigation, serial ECGs, Holter monitoring, potentially stress testing or provocation tests, and you are likely to end up in the EP lab, and again really looking to make sure whether you've got multiple pathways and short fracture. As I said earlier, symptoms are the most important indicator that we take into account. Success rate is high, however, recurrence is not unheard of, and again, just at the bottom, the complication rate again is not high, but again, having a 1 in 1,000 risk of death for an ablation, a 1 in 200 risk for a stroke, is not insignificantly young for a population. Eddie, I think, will make us an update as to the current WPW approach after I've finished speaking. But essentially, I think if you have no symptoms and your non-invasive test was abnormal, certainly our view in the Air Force would be essentially that we would probably let you continue flying with close follow-up, but clearly the moment you get symptoms, you are likely to be grounded and require significant investigation. XP is probably the biggest bane of my life. This is extremely common, and as has been said before, you are allowed one ectopic beat on a standard 12 ECG. Any more than that, you require further investigation. It's common, about 6% of tuner ECGs will have significant ectopy on it. Male predominance, it increases with age, as you've heard, and actually the more complex it is, the more likely you are to have underlying cardiovascular disease. One of the key determinants in terms of the outcome with ectopy is whether you abolish the ectopic beats on exercise, and this is the reason for doing this. And you can see here that actually there is a significant difference, in fact, if you have ventricular beats during exercise, and it is not that far off having ischemia on exercise. So this is something that we shouldn't dismiss lightly, and therefore that is the reason for doing the exercise test, is to see whether, and the vast majority of people will suppress their ectopy, but if they don't, it clearly is an indicator to take it more seriously and probably do some further investigation. Certainly our experience over the last couple of years would suggest that you need to be very careful and consider the underlying etiology for this, and we have had a reasonably high pickup rate of underlying cardiomyopathy. But the other thing to say is a high burden of ventricular ectopy may well in itself lead to a tachycardia-induced cardiomyopathy. So there is an element of cause and effect. And for that reason, in addition to doing the standard 24-hour tape echo and exercise test, we will quite often go on and do cardiac MRI scanning and potentially CT coronary angiography, depending on the age of the patient. If tests are normal and there is a low ectopy burden, by which I mean less than 2%, you may well be able to return to an unrestricted flying action. But in most scenarios, people end up with an ASL with restriction due to the fact that we have relatively little way of predicting further progression into higher burdens, and we often find that if we follow these people up, actually they're 2%, becomes 5%, becomes 10%. The other thing to say with the ectopy group is the fact that you often find this in very fit people. As we probably are all aware of, exercise is good for you, but lots of exercise is not necessarily good for you. And certainly high levels of exercise not only reduce your G tolerance, but may well significantly increase your risk of not only ventricular, but also atrial ectopy. And the problem is often by the time these people come and present to us, we find that even if they detrain, actually the damage is done and they retain their ectopy. This is the scenario we don't want to find ourselves in, but again, if you do standard 24-hour Holter monitors with people who have ectopy, it's not unusual to find them having significant runs of 30 or 40 seconds of VT. And again, this clearly puts you in a much higher risk group. There is some debate about how one defines VT, and again, you can see from here, in the US, 11 beats is the cutoff, with relatively few episodes in 24-hour periods, whereas we in the UK would regard that non-sustained VT being benign would usually be 4 or 5 beats or less. So again, there's already some discussion. One of the debates for, I think, the cardiology community and the aviation cardiology community is to try and have some kind of consistency when we are talking about how we treat VT. There is a general rule of thumb. Most people are grounded. You may be able to get a multi-crew license if you've got a structurally normal heart, and the only time that you have VT is induced either under high G or exercise. The final point I want to make is just about athletic heart. We have some very fit people, and we have a lot of people in uniform who like to go out there and prove quite how manly they are by doing Ironmans, triathlons, and all the others. And whilst I'm a fan of people exercising, we do have to be careful what we advise people. Athletic heart is not a benign condition. You are a significantly greater risk of getting atrial fibrillation, non-sustained VT, and VT. And whilst, there's been a lot of debate about athletic heart and saying, well, this isn't a cardiomyopathy, so it's okay. I'm afraid I don't share that view, because athletic heart may not be a true cardiomyopathy, but actually the bulking of your heart muscle beyond a certain point that you can't essentially supply a decent heart supply to, you will find that you end up with some arrhythmia. So in summary, arrhythmias are common, and they may result in in-flight incapacitation and distraction. They often, and I would say usually, require extensive clinical investigative screening, and actually it is often difficult to be clear in the early stages as to what the administrative outcome will be. But on the whole, people who present with arrhythmias at best will end up getting back with an ASL category in the vast majority of cases. So, back to the question, which was, in the RAF, pilots with established AF are safe to fly in an unrestricted capacity in which of these scenarios? So adequately rate controlled, on digoxin, if asymptomatic, after successful ablation, or not at all.
The channel is open to vote. Same 60. Okay.
Yeah. So a slight change. I mean, the answer is that you are unable to go back to a fully unrestricted flying category because of the 5% recurrence rate in the longer-term follow-up data. So actually, if you get an established atrial fibrillation, you are unable to go back. By established, I mean not a single isolated episode. So the art is fine. Thank you very much.